We're talking today with Dr. Michael Cackovic from the OSU Wexner Medical Center. This is Women's Health Week, and Dr. Cackovic, thanks for joining us. And what are some of the issues that you would like for women to think about this week?
Hey, good morning. I guess the biggest thing, I think you can put women's issues into two categories, pregnancy and non-pregnancy, or GYN. I think that as far as pregnancy goes, one of the issues that's facing us right now is that a lot of women possibly aren't getting the care they need because there's too much emphasis on the fetus or the care of the fetus. And one of the things I tell my students and residents that I work with is the most common cause of fetal death is maternal death. And I know that sounds like a dramatic explanation, but it's true. I mean, we have to take care of our moms. We have to keep our moms healthy. So you can't withhold treatment based on the fact that she's pregnant. You have to actually treat her as if she weren't pregnant and deal with if there is a consequence or a risk to the baby, the benefit to the mom outweighs the risk. So I think that's something that's kind of coming full circle now in our discipline about not forgetting that the mom is the most important part of this equation, because if we don't keep her healthy, the baby's going to suffer as well. And the example of this is with depression. There's been some reports in the last couple years about withholding antidepressant meds to mom because they may have some effect on the baby. One of the effects for the baby is neonatal abstinence syndrome, but the risk of that is about 1 to 2%, and it's self-limited and goes away and doesn't cause any long-term problems on the baby. But if we withhold antidepressant meds in a woman who's really depressed, I mean, you can imagine what can possibly happen to that woman during pregnancy or after pregnancy, and by consequence the baby as well. So that's just kind of an example of some of the challenges that we have now in perinatal medicine.
And what are some of the other health issues or concerns you would have for an expectant mother?
I mean, the other thing, too, has always been weight gain and weight loss. I mean, we don't obviously ever advocate losing weight in pregnancy, but the bottom line is that women need to stay healthy. And obesity is an epidemic in the United States, something that we see every day in Ohio as well. And women need to stay fit. And the women that's thinking about getting pregnant should take that opportunity to get down to a reasonable weight, exercise, and start an exercise program and continue that exercise program when they're pregnant. Too often times they get some pressure from family members and such that they're not eating enough and they overeat, and obviously that also causes problems with the pregnancy and with the baby as well. So I think that good preconceptual care, talking to your doctor when you're considering pregnancy, is the opportunity to really kind of get to the bottom of all those issues. I mean, let's face it, young women don't go to the doctor. They don't need to go to the doctor. They're generally pretty healthy. But if they want to have a pregnancy or a healthy pregnancy, it's a good opportunity to go to the doctor, find out if there's anything that they need to do or anything that they can get in control before pregnancy occurs.
And if you're talking to a woman who maybe doesn't want to get pregnant or is done having children, what are some of the options that women today have in the birth control range?
Well, a lot of things are basically, I think, short-term and long-term contraception. I mean, a woman that doesn't want to have any more children but doesn't want to commit to sterilization or tubal ligation, an IUD is a perfect option. There are basically two types of IUDs on the market. There's IUDs that contain progestin that can be left inside for 5 years, and then there's ones that contain copper, which can be left in the woman's uterus for 10 years. And those are excellent methods of contraception that actually the failure rate is much less than surgical sterilization or tubal ligation. But if a woman wants to have a baby and is family planning, something like the pill or the NuvaRing, which is a contraceptive insert that a woman uses monthly, is a good option because they can finish out their cycle, go off of it, and ovulate and get pregnant again. There's some longer-acting progestins that are also used that are easy to use, like Depo-Provera, that you take every 12 weeks. The problem with a woman who's trying to not raise a family, but to plan a family, is that the return to fertility on those medications can take a long time. So they're basically not really the best for somebody who's planning on having a child, every 1 to 2 years. Usually the pill or just barrier method is usually the best thing for a woman who's just kind of planning out family.
I was just preparing for this interview, just thinking about women's health in general. I was looking at some of the diseases and things that women need to be concerned about, and they're very similar to the ones that men would, heart disease and cancer and other things like that. So I imagine with any disease, what I always hear when I do these interviews is go see the doctor regularly and make sure that if there is something wrong, it's detected early.
That is correct. And another example of that is the one disease process that we worry about in pregnancy that's unique to pregnancy is preeclampsia. Preeclampsia is an interesting disease because we know what the cure is, but we don't know what causes it. There's lots of theories, of which one of them is genetic, that it's almost like a half the baby we know is foreign and half the baby belongs to mom, so perhaps it's some sort of kind of rejection of the foreign DNA in the baby. Again, that's just a theory. But the whole basis of prenatal care in the United States and in most developed countries is the screening and management and evaluation of preeclampsia. And, as anybody that's been pregnant knows, about the 9-visit pathway, usually about 9 visits for a routine pregnancy, but they're backloaded. So most of those occur, you're seeing them every month until about 28 weeks, and then every 2 weeks till about 36 weeks, and then every week. And that's really to manage preeclampsia. And preeclampsia has been shown to be a risk factor for heart disease in the future. So it's also good that if a woman has had a pregnancy that's been affected with preeclampsia, that they let their primary care physician know that so they can be screened and seen regularly to make sure that hypertension or heart disease or cholesterol or any other issues actually develop later in life. So it's kind of like a stress test for heart disease.
Where does the OBGYN come in when it comes to the overall health of women? And is there a rule of thumb on how often a woman should see an OBGYN as opposed to just seeing her regular family physician?
Well, that's a great question. Obviously, most women see their OBGYN, they're pregnant or contemplating pregnancy, or if they want to know birth control options. I think a lot of primary care doctors or family medicine doctors are very comfortable talking about those kind of things, and if not, they can refer to the OBGYN. It's kind of a little bit in flux now. Women used to automatically go to see the OBGYN every year and get a pap smear, but now that some of those requirements have softened a little bit, if a woman never has had an abnormal pap smear, it isn't at risk for cervical cancer or cervical dysplasia, so they often don't have to go. But usually I think that it's a lot of women, especially middle-aged women, are still in that process of going to see their OBGYN once a year. And it's one of the reasons why I went into OBGYN actually is because, it's long-term. It's a little bit of prevention, it's a pregnancy, it's dealing with certain GYN problems, and then it's nice to see patients that you've delivered their babies every year for subsequent years afterwards.
And should women, when they come to the doctor, should they have a list of questions if they have any issues at all?
I love that because I don't personally have a spiel. I try to treat everybody as individuals, so I love when they have questions. I love when they're written down because it shows they're prepared and they have particular issues. So, I mean, maybe some doctors don't like that because it takes up time, but personally I do like that. But one other thing, is that with breastfeeding, we always advocate breastfeeding, and sometimes women with medical conditions are on certain medications that may not be compatible with breastfeeding. So that's always a good thing to ask your doctor when you're pregnant, so it's not something that comes up as a last resort after you've delivered. You're like, can I breastfeed on this particular medication? So when I do a consult on somebody with a medical problem, that's another thing I try to put in there about what the American Academy of Pediatrics says about lactation and using the medication in breastfeeding, because a lot of the medications do cross, but most of the time it's not in a large amount, but you always want to make sure that amount is safe for the baby.
And again, right there with asking the questions would be come in prepared to tell your doctor all the medications you're on.
Exactly. 75% of diagnosis is history. So, a lot of, now that we're in this kind of computerized world, everything's in the computer, and a lot of people still rely that, it's going to be in the computer, don't worry about it. But the reality is what you tell me is what I can deal with, and I'd much rather hear it from you than reading in a computer anyway.
Very good. Well, thanks so much for talking with us today about Women's Health Week.
All right. Thank you for having me. I appreciate it.